Hi, this is Dr. Patrick Agnew, uh, communicating from Virginia Beach, Virginia. I hope everybody's enjoying the meeting, and I would be grateful for about 20 minutes of your time to talk about soft tissue surgery in people with collagen diseases. You can see some of my credentials there. I run a residency program as director emeritus here at Eastern Virginia Medical School in foot and ankle surgery. And we just created a new department chair, and I get to do that because I was probably too dumb to say no, thank you. But we'll see how that goes. Uh, I did serve in the Navy for about 20 years of mixed active and reserve service, and retired from the Navy, where I also worked as a CB combat warfare officer doing naval construction. Um, Also am still on the board of directors and past president of the American College of Foot and Ankle Pediatrics, kind of a small subset in podiatry. So I bring you greetings from the American College of Foot and Ankle Pediatrics, Eastern Virginia Medical School, and the Children's Hospital of the King's Daughters, the places where I work every day. A little bit of previous research I've done in connective tissue disorders. A lot of it kind of anecdotal, collecting information at national meetings and local meetings, also from my own clinical experience. Also, I have published a number of posters at national and international meetings, and of course, recently co-authored a chapter in a book from Dr. Frank Omano called Symptomatic, which I highly recommend. So just brief overview of connective tissue disorders and their relevance to foot and ankle problems. We're often taught in foot and ankle surgery to think of hypermobility in joints. And sometimes the discussion revolves around hypermobility in a joint. And that certainly can happen. But in my experience, a lot of patients who have been told that they have a hypermobile joint actually have a whole lot of hypermobile joints, and nobody ever really stopped to look and see if that's the case. This can lead to some bad outcomes and bad decision making. So this slide's very outdated, but it's intended to show people who aren't that familiar with connective tissue disorders about just a few of the very many possibilities of how they can have hypermobility associated with collagen disease. So a few collagen disorders that most podiatrists and physicians are alerted to in their primary education include the prototype osteogenesis imperfecta, but also Ehlers-Danlos syndrome, or syndromes, we probably should say. And Marfan's used to get the most exposure, I would say, or had a very effective communication program, probably because of the sudden deaths occurring in athletes. My son on the left there is very flexible, but not hypermobile, and just happens to be a really good surfer. On the right, you can see, on your right, my left, you can see the hypermobility of the first toe in a patient of ours. We won't belabor this. The types of Ehlers-Danlos syndrome have increased and decreased over time. This slide's actually a little obsolete. I should say more types and deeper understanding now, as the Human Genome Project and the HEAD study and other efforts have elaborated more types of Ehlers-Danlos syndrome. What are the basic principles of treating patients with connective tissue disorders? Well, we want to handle soft tissues carefully. There can be vascular fragility. The bones can be fragile either as a direct aspect of the disease or possibly from disuse atrophy. Most people have kind of a flat foot, but it may not be pronation. It may be kind of a sagging thing we'll talk about more in a moment. Even though every joint in the body might be hypermobile, the Achilles tendon can still be tight, creating a problem called equinus, named after horses, or equestrian, where the patient kind of tiptoes, or the tightness in that heel cord can contribute to malfunction in the foot. Also, ankle instability is fairly universal, so it's very easy to twist the ankle, sprain the ankle, sometimes without pain, but often with damage to the cartilage surfaces. And then all the other things that seem to be comorbid, like pectus, Chiari, MCAS, or mast cell activation, and postural orthostatic tachycardia syndrome. Some common foot problems include hypermobility within the foot and a very flat foot, which may just kind of sag. Pronation is a pretty specific and desirable movement of a foot. It's what allows the foot to adapt to uneven surfaces. And then later in the gait cycle, the foot becomes rigid and becomes a good lever for propelling a patient forward. In the case of hypermobility disorder, sometimes the bones are all aligned appropriately from the start, but then they just sag along the middle because of laxity within the ligaments that are supposed to be holding those bones together within the foot. 1 out of every 4 bones in your body being in your foot and connected by many, many different little ligaments that may not work properly. Some common foot problems that are seen in people with hypermobile feet are bunions, where the big toe joint protrudes medially and makes it difficult to find shoes that fit properly. And this is kind of an uncommon manifestation where a bunion actually had surgery. You can see the adhesive tape on the left foot of the patient. And if you look closely, you can probably see an incision line directly over that pseudotumor or cyst, which is developed when after the patient had surgery by another doctor. And unfortunately, soft tissue closure was not effective. So deep fluid and soft tissues are protruding like a hernia out the medial side of the foot. See if this video will run. Of course, most people here are probably aware of hypermobile capabilities and things that you should never do once you've done once. So once someone has seen that you can do 9 out of 9 points on bite and scale, or you can do little tricks with different joints, don't do them anymore. Every time you do these things and exceed the normal range of motion of joints, you can do damage. You can also see on the bottom slide, the patient standing on the blue piece of paper has an unusual presentation of a fairly common birth defect called metatarsus adductus, and has compensated with severe pronation of the rear foot. So the ankle's almost touching the floor, and the curvature of the foot is highly abnormal. This is often seen in very mild forms. I actually have this myself. I've written chapters in 3 different books on it. It's ironic that they asked me to write about it. They didn't know that I had it when they asked. They said, "Can you talk about metatarsus adductus?" And I say, "Yes, I can." It's a little bit of a challenge. It can make it difficult to wear shoes, make you more inclined to roll your ankle, make you more inclined to fracture your 5th metatarsal. And it is more common in people with connective tissue disorders or babies born with connective tissue disorders. Presumably, well, in an infant, the ligaments are strong and the bones are soft and malleable. So the ligaments are not protecting those soft bones in a patient with connective tissue disorder, and those bones are more inclined to become deformed. As in this case, you can see, again, metatarsus adductus on my right, and then the patient kind of standing on the side of his foot has a club foot, and that's more common in people with connective tissue disorders, again, because the fetus is not protected from the uterine forces by normal ligaments. So what do we do about it? Well, we try to align and maintain function. This is necessary because left alone, the joints will work outside of their normal range of motion and deformities will develop over time. As we're using bracing, splinting, surgical treatments, we got to be careful with the skin. Healing can be difficult. Wound closure can be difficult. A lot of operations in the foot and ankle rely on ligaments. And if ligaments are inherently flawed, that can be kind of foolish. And so we have to come up with other ways to get good results. And we want to select the timing, particularly of invasive treatment well. Ideally, we want to intervene non-surgically as early as possible with bracing, splinting, exercise, all which will be discussed thoroughly during this conference by other providers. But sometimes if surgical treatment is indicated, it can be wise to get at it sooner than later, as the damage to joints and deformities of bones will tend to progress left alone. So in aligning and maintaining functional anatomy, we can use orthotic arch supports. Sometimes we'll do extra osseous surgical procedures like arthroresis, which we'll talk about later. Arthrodesis is fusing joints. My experience in people who've had fusion of joints in their feet is that there generally are bad outcomes. My thought process behind this is that if you fuse one joint and let all the other joints still flop around, they really get angry. And this can translate all the way up the weight-bearing skeleton. Osteotomies, where bones are cut and put back together, can be effective as long as the surrounding tissues are treated appropriately, as long as bone density is sufficient, or sometimes they work just to take a bit longer to heal. The talotarsal joint stent, or arthroresis, we'll talk about in a moment, and ligament replacement is something we've been trying to pioneer at our facility. So talotarsal joint stents are a little thing that looks about like a bullet. I'll show you a picture in a minute. It helps to create an arch by putting the talus back on top of the calcaneus where it belongs. One must be aware of their goals with any procedure, as well as advantages and disadvantages. So the goal is relief of pain, not necessarily building an arch. And this is where people go wrong sometimes. They'll put in too big of an implant. We'll talk more about that in a minute. We want to improve alignment and function of that joint, but also surrounding joints that are influenced by that joint. And we want to interrupt that pathomechanical progression that I mentioned a moment ago, where joints and tendons all become gradually more and more deformed and dysfunctional left alone. And correction of deformity, I don't know if that's a realistic goal. When we talk about a flat foot, sometimes it's referred to as a deformity. I think sometimes that's a reach. It's more like a spectrum. It's more like at one end of the spectrum of what a foot functions and looks like. But how it looks really isn't my concern so much as that it work appropriately and comfortably. So some different types of subtalar stents that have been used in the past go all the way back to the 40s, where a piece of bone was put into an area of the rear foot called the sinus tarsus. Later, plugs made out of celastic were used and hand-carved. Polymer implants became popular for a while. Most of them are metal now. Absorbable stents have also been tried, but these are impractical and inappropriate for people with connective tissue disorder because although they can align the joint initially, if they dissolve and go away, that joint's going to go right back to what it likes to do, which is not what we want it to do. So a little bit more history on these stents. The one on the right under the word history is one that was put into a hole in the calcaneus called a stapeg. Actually, both of the top ones are. These are not in real common use currently, and they are, of course, more invasive, having to drill into the bone. The bottom two are some variations of metal implants, and one here that contains a flexible polymer and a screw device that can expand and contract it to fit. This is the most common one I'm using currently. It's titanium, It's actually been modified further so that the threads are no longer spiraling like a screw, but can help stay in place better by being concentric rings or multiple rings rather. On the young lady's necklace, she has a stent that didn't work out great and had to be replaced, and she turned it into a necklace. Happily, that doesn't happen often at all. But I would say that one of the advantages to this procedure is that it is reversible. You can unscrew it. There aren't a lot of things in life you can unscrew, but if this thing is uncomfortable or ineffective, it can be removed pretty easily, about as easily as it's put in. So the size of the stent matters, as photography by my wife matters. She took this picture way too late. If I was on that wave earlier, it would have looked like the one behind me instead of the one under me and in front of me. There was a study done comparing absorbable versus non-absorbable subtalar stents, and that it wasn't really successful in determining one over the other. As I say, I don't agree. I don't recommend absorbable stents in people with connective tissue disorders, as the condition is at this point permanent. But they did do CT measurements of the size of the place where we put the stent, and it turned out to be quite a bit smaller than we thought. And so people were shoving fairly large stents into this spot and sometimes causing discomfort or overcorrecting, making a kind of high arched or cavus foot that would tend to tip over the other way. And that's certainly not our goal. So you want to choose the correct size based on function more than appearance. As far as ligament replacements, this guy's talking about cosmetic foot surgery, which kind of makes me throw up in my mouth a little bit. I think that feet are funny looking at their best and proof that God has a sense of humor, and that making them just look better is not really the goal again. But he is also talking about a procedure using strings and endo buttons to put bones where they belong. And we have had some pretty good results with these. And it kind of makes sense in a patient that's generally flexible and has bad ligaments. You may be able to line up bones without having to cut them, and certainly without fusing them. Also, usually these kind of things you can stand on immediately. Now, why do we want to line things up? Well, we don't want arthritis. And if the joints are out of alignment and subluxing and dislocating, it's going to damage the joints. Here we're replacing the cartilage in a first toe joint that has been damaged from that sort of hypermobility. This is a video from a company I have no alignment with. It's a kind of a cute video talking about using endo buttons and sutures to try and realign the first metatarsal. The way in which they do this is different than how I recommend, because they've got the wire going from plantar to dorsal. And when you pull that string tight, what you do is pull the first metatarsal up in the air in the sagittal plane. This causes overload of the second metatarsal. And historically, this procedure had a high incidence of stress fractures of the second metatarsal. The stress fractures occurred not because there's a little 2.7 millimeter hole in it, but because the first metatarsal has been elevated, causing overloading and chronic repetitive stress on the second. Here's an example of a patient. You can see her knees and her skin are fairly typical for classic type EDS, and she has a large painful bunion. What we did there was these buttons, and also a little osteotomy on the head of the metatarsal to realign the cartilage. Finally, we put some other endo buttons and suture material into her first toe and her first metatarsal to help align the toe. So this is a minimally invasive surgical procedure. Apologize, I probably should have warned you there's a cadaver specimen where we did some experiments to see the strength of the ligament that's supposed to hold the toe straight. We found it's only about 40 to 50 pounds strong. So small suture materials can cause or can be strong enough. I apologize for the noise from the video. I hope you can still hear me. So here we've put an endo button into a cadaver's first toe and another one into the first metatarsal, and we're tightening a little string connecting them and straightening the toe. We also use sutures and buttons to replace ligaments of the ankle. I don't use this particular system. We use some different bone anchors and suture, but I think this is a very wise way to stabilize the ankle of a patient with a connective tissue disorder. We also looked at the strength of the ligaments of the ankle, and we think that for everyday use, the kind of sutures and buttons we're using can be very effective. So we wind up with this construct that we do on a lot of patients with connective tissue disorders through a very small incision, as you can see on the lateral ankle of this patient. So bone anchors going into the talus, the calcaneus, and the fibula, and then a stent in the subtalar joint and their sinus tarsus can be a great way to stabilize both the subtalar joint and the ankle in a patient with a connective tissue disorder. Thanks to a friend of a patient with Ehlers-Danlos syndrome for those very sophisticated videos. We have to be creative. Sometimes treating a patient with Ehlers-Danlos syndrome is a little like pushing on a balloon. You solve one problem, create another problem on the other side. Here's a patient who did not step on an anti-personnel device. This is all deliberate surgery. And then she's had the ligament between her leg bones stabilized, the groove for her perineal tendon deepened, her subtalar joint stabilized with a stent, and her lateral ankle stabilized with multiple bone anchors and sutures. So there's a lot going on there, but she's walking around. So that is the end of my canned comments. I hope that we have I think we have a panel discussion coming up soon. Thank you for your attention.